Good afternoon and welcome. I'm Angela Taylor, the Director of Programs for the Lewy Body Dementia Association, and I'll be your host and moderator for today's event. LBDA is pleased to offer this webinar as part of our LBD University event series. This event is sponsored by an unrestricted educational event by Axovant Sciences. The webinar is being recorded and will be available for on-demand viewing in just a day or so. Today's guest is Dr. Alain Avidan, who will present sleep issues in LBD. Dr. Avidan is a professor of neurology, vice chair of clinical educational affairs in the Department of Neurology at the David Geffen School of Medicine at UCLA, and he's the director of the UCLA Sleep Disorder Center. He completed his neurology residency at the Georgetown University Medical Center, and after residency, he completed fellowship training in sleep medicine at the Cleveland Clinic. He's published over 100 chapters, letters to the editor, peer-reviewed articles, and has edited 5 textbooks in sleep medicine. And his research focus includes the impact and prognostic implications of sleep disturbances on underlying neurologic disorders. He enjoys educating physicians about the public about sleep disorders and has recently received the American Academy of Sleep Medicine's 2014 Excellence in Education Award. Today's webinar will begin with Dr. Avidan's presentation, and that will be followed by a question and answer period. So please feel free to submit your questions using the question and answer box at the top of your screen. And following the presentation, I'll present your questions to Dr. Avidan, and we'll address as many of them as possible in the time allowed. And now I'm pleased to turn things over to our guest, Dr. Avidan.
Thank you very much, Angela. It's a pleasure to be here, and let me go ahead and share my presentation with everyone. So it's a delight, it's an absolute delight to have the privilege to talk to you all about sleep disturbances in Lewy body dementia. And I will start by telling you that, actually I mentioned this to Angela earlier, that I think I have a very strong connection to sleep medicine because, as you can see, my last name is Avidan, but most patients call me Dr. Avidan. So I think I'm particularly well connected to sleep, especially in patients who have insomnia when they come and look for me and ask for me by Dr. Avidan. So let's talk about sleep. For the next half hour, my goal is really to give you some insights into some of the sleep disturbances that affect patients with Lewy body dementia and really everyone who has some sort of a neurologic condition and underlying neurodegenerative condition, and also individuals who are just getting a little bit older, and discuss some of the signs and symptoms of the sleep disturbances and when is it really important to get clinical help for those conditions. And also give you some, begin with giving you some of the theories about why we sleep. I think that's really fascinating because over the last few years, we've gotten more and more knowledge about some of the theories about why we're spending a third of our lives sleeping. If throughout this presentation you have any questions, please go ahead and type them and submit them so we can go through and review them during the Q&A session. So I'm going to start by going through my disclosures very briefly, and none of them are really pertaining to this particular presentation. And let's begin by talking about why we sleep. First of all, there is an interesting theory which is that sleep is restorative. And what ends up happening during the night is that sleep is often a time in which our memory is consolidated. We're spending time taking all this information that has been accumulated during the daytime and consolidating it and making more and more space for more information to be accumulated the next day. So as you can see in this diagram, all the red areas, areas in the top panel of the diagram represent places in our brain, which is information that we probably don't need, and that information is removed, and we store information that is vital, that's shown in blue, and that information is consolidated, and that's vital because we're making more and more space and storage for information that we can gather the next day. So sleep is somewhat important and restorative for memory consolidation the next day. If you don't sleep well, your memory and cognitive abilities tend to decline. Here's the next slide. Sleep is rejuvenative. So this is actually a very important new data. This is based on the fact that within the neurons of the brain, there is a glymphatic system. The glymphatic system is actually the brain's own lymphatic system, which is particularly effective and active during the night. And what the glymphatic system does is it removes garbage and the byproducts that accumulate during the day, and removes it. And essentially what it does is that that particular system is primarily and almost exclusively active during sleep. So during sleep, and one of the important functions of sleep is for the glymphatic system to remove all that byproducts and the toxins away from the brain. And much like I'm showing you in this following slide, the brain is mainly during sleep, the glymphatic system is being active and is removing all this garbage out of the brain, and failure to get good amount of sleep would not allow one to get clearance of this byproducts from the brain. And what ends up happening is there is now data from laboratory animals that there's accumulation of abnormal proteins during the night, and that some of these proteins are found in Alzheimer's dementia. So some of the questions that arise is, well, what happens if patients do not get a sufficient amount of sleep or have poor sleep quality? Is it really a risk for dementia? We don't really know if that's really the consequence, but certainly it makes sense to get good quality of sleep, because we now understand that if you don't, you are at greater risk for potentially accumulating proteins that may not be good for the brain. So having a good quality of sleep is both restorative, rejuvenative, and allows your glymphatic system to work more effectively, so as to clear away proteinaceous substances and toxins to make it more rejuvenative for the brain. And this is shown in the cartoon, as you can see here in this film. The glymphatic system flows through the neurons. The substances in black are all the abnormal proteins, and the glymphatic system essentially carries them to be removed by the glymphatic system back into the circulation. So this is really important, and this system was only, its function was only characterized in the last few years. And it's important because we're now realizing that sleep is really an active process. In the past, it was thought that sleep is not very active. Everyone is aware that when you're sleeping, nothing really is happening. But this is really to show that, on the contrary, sleep is a very active process. You have a lot of things going on in the brain, clearance of abnormal proteins, defragmentation of memory, really consolidation of a memory, and rejuvenation of the brain, and lack of good sleep are going to put a patient at risk for more disease and more poor health. Okay, let's move to the next slide. Can you know, this is a question that I'm asked on a regular basis. Can you get by with less sleep? And this is a question I see patients who tell me, well, I only need 4 or 5 hours to get by, and that's not really healthy. We know that most adults need about 7 to 8 hours of sleep. If you get less than 4 hours of sleep, you're putting yourself at risk for cardiovascular disease, diabetes, heart disease, and depression. So I really want to stress that sleep varies by age groups, but you can see for adults above age 18, it's really recommended that adults get between 7 to 9 hours of sleep. This is by the National Sleep Foundation. Later, the American Academy of Sleep Medicine and the Sleep Research Society recommended that is maintained at about 7 to 8 hours. Less than that, and even more than that, is not really conducive for proper sleep. So, adults should get 7 or more hours of sleep regularly. That's the other thing. Regular sleep on the weekends, on the weekdays, in order to promote optimal health. And there was a interesting concept that was discussed at our last national sleep meeting, that social jet lags, those individuals who are maintaining irregular sleep schedule on the weekends, are also at risk, even though they're getting sufficient amount of sleep. Even if they're having irregular sleep on the weekends, that can put them at risk for cardiovascular disease. So less than 7 hours of sleep can put you at risk for obesity, diabetes, high blood pressure, heart disease, stroke, depression, even increased rates for death, increased pain, depressed immune function. This is more germane to folks who are operating in specific occupations, like in the medical field, more errors, risk for accidents, certainly, and this is really important. Now, you can see that sleep disturbances do tend to increase with aging, and you can see almost an exponential rise after age 60 or so, and that may have to do with the fact that older adults tend to carry more comorbid medical problems, more pain, more sleep apnea, more restless leg symptoms, and more medications. And everything tends to become worse. Patients who have more sleep apnea tend to have worse sleep, and that tends to correlate with increased age. So I think that's important to realize, that sleep per se is often affected by the aging process, but it doesn't have to be this way. I think that if you note that you have poor sleep, you shouldn't resort to only getting 4 or 5 hours of sleep. You should still try to optimize your sleep duration and ask how you can improve your sleep quality and duration in order to feel more refreshed the next day. So my next slide and the rest of the presentation is going to review some of the specific sleep disorders. And we're going to start with obstructive sleep apnea. Sleep apnea is very common in patients with dementia, particularly with Lewy body dementia. The underlying lesion with sleep apnea is an obstruction at the level of the pharynx, where the airways tend to be very relaxed, and that is affected by weight, that is affected by age, by alcohol. Alcohol tends to also relax the airways, and that's why after having a few glasses of wine, people tend to snore more, and that tends to even convert someone who has just simple snoring to more severe sleep apnea. And when we treat sleep apnea, really our aim is to open up the airways. Here's a patient with sleep apnea. You can hear him snoring. He's coming in for a sleep study, and you can hear the patient is snoring, gasping for air. Right now, he actually stopped breathing, and you can see he's gasping for air. He's trying to move air across a closed airspace. His chest and abdomen are really not moving correctly, but hopefully he's going to start breathing again. And I think now he's going to take a breath and start breathing, and the cycle will continue. Here we go. So that was that whole time in which the patient was not making any sound was an apnea. Patients will have 20, 50, 80 times in which they stop breathing per 1 hour of sleep. And of course, the treatment is really critical. The treatment for patients who have sleep apnea is the CPAP therapy, positive pressure therapy using the mask. It's really the gold standard, the most effective treatment for these patients. All right, let's move to the second, probably the most important sleep disorder in patients with a Lewy body dementia. This is a parasomnia. Parasomnia is an abnormal behavior that occurs during sleep. And this particular parasomnia is called REM sleep behavior disorder. REM stands for rapid eye movement. This is the type of sleep stage in which you are dreaming. And you can see in the cartoon here, the patient is dreaming of fighting. And what ends up happening in this patient is that, you know, when you're dreaming, your muscles are supposed to be paralyzed. And it's a protective mechanism to prevent yourself from acting out your dreams. And guess what? Patients with REM sleep behavior disorder, or RBD, RBD is the same as REM sleep behavior disorder, that's the acronym. Patients with RBD tend to act out their dreams. So if they're fighting or if they're getting rid of an intruder, they're actually doing this in real life. And the concern is that they're going to injure themselves. If they're going to kick someone, they're actually going to kick a wall, or worse, they're going to kick their spouse. So it's very, very important because there is an implication for injury. Many of these patients come into our clinic because they get injured, and that's where we have to put them on medications. So here's the diagram that I wanted to show you. This is how parasomnias occur. This is an incomplete transition from one sleep stage into another, and it's a rapid isolation from REM sleep into non-REM, which is slow wave sleep, into wakefulness, and that incomplete transition from one sleep stage into another precipitates the parasomnias. Now, RBD is the most common parasomnia associated with neurodegenerative disease, particularly the alpha-synucleinopathies. The alpha-synucleinopathies, as most of you know, is a group of neurodegenerative disease based on the alpha-synuclein staining in the neurons that comprise of Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. Now, what's interesting about RBD is that the condition, RBD, often presents before the onset of the neurodegenerative disease. Many of these patients don't know that they may be at risk for the dementia. So as a neurologist practicing sleep medicine, I think this is a really important condition because we can actually predict that when we diagnose someone with RBD, we're not only diagnosing them with a sleep disorder, we're also diagnosing them with a potential neurodegenerative disease. And if we do, that's a point in which we have to tell them that there may be at risk for dementia later in life. So this is a point in which the particular condition, RBD, is really the tip of the iceberg, that with time, these patients may go on to develop a neurodegenerative disease. And the timeline is usually 10 years, that maybe two-thirds of patients will develop a neurodegenerative disease. That's what the typical literature tells us. Of course, there is a range, and this is just some basic formula, but generally speaking, most of these patients will go on to develop a neurodegenerative disease, and the longer you wait, the more likely the patient will develop the condition. And with dementia with Lewy bodies, REM sleep behavior disorder is particularly important. In fact, it's so important that REM sleep behavior disorder can be used to diagnose patients with dementia with Lewy bodies. Okay, now I mentioned to you that many of the patients who enter their dreams are sometimes fighting, and sometimes they dream about intruders. The point of my review is that the dreams are rarely pleasant. They're often defensive dreams where the patient has to defend themselves against other people, intruders, animals. They're rarely pleasant dreams like sports or adventurous dreams. Here's a dog with a dream enactment behavior, and you can see how aggressive some of this dream enactment can be. So this is a dog with a REM sleep without atonia. The dog is dreaming about a dream, or dreaming about running, and is actually doing this in real life. So this is exactly what happens in patients with REM sleep behavior disorder. So the treatment, number one, safety, removing any sharp objects from the bedroom environment, sleeping alone to make sure that the bed partner doesn't get injured, and then we also intervene with medications such as melatonin and clonazepam. In my opinion, melatonin is actually the safest treatment because clonazepam often has side effects like sedation, sleepiness, and can make people very groggy the next day. Some patients do not know that they have RBD, and they may go through and actually construct some contraptions to prevent themselves from acting out their dreams. This is from a picture from one of my patients who actually created a seat belt and a handcuff contraption to prevent himself from acting out his dreams. And this is how he went to sleep every single night, almost like a prisoner in his own bed. We now have more data about the fact that RBD could be a window of opportunities for patients with Lewy body dementia, in that perhaps it could be medications and specific pharmacologic treatment that potentially could help delay the progression of the neurodegenerative disease later in life. And here is some information about clinical trials. This one is actually an NIH clinical trial that is currently available for enrollment, and actually the study is ending in June, so just a few more days, but it's coordinated at the Mayo Clinic, and there'll be more studies available, I'm sure, but this one is helpful because it's using RBD as a biomarker to help put patients on medications that could potentially delay and help prevent the underlying neurodegenerative disease. In the last 2 minutes, restless leg syndrome and insomnia. Restless leg syndrome is an urge to move the legs in the evening time. Many patients with Lewy body dementia have this condition. It's very bothersome, and they often don't know that they have it because physicians often do not know how to diagnose restless leg syndrome. But many patients will resort to things like using a baseball bat to hit their legs before going to bed. And this is really very dramatic because the pain is so severe and so uncomfortable. The only thing that really helps these patients before going to bed is taking a baseball bat, hitting their legs, and that's the only thing that relieves them, the discomfort from their restless leg symptoms. Again, the symptoms are worse during the evening time. They get better with movement. They get worse with inactivity. The worst thing is flying, driving long distances. This is really what makes your life really miserable. But there are very effective treatments right now for this condition that are very, very effective, so patients don't have to resort to extreme means like using a baseball bat. All right, I'm going to end with insomnia. A third of patients with neurodegenerative disease, dementia with Lewy body, and Parkinson's disease will be affected with insomnia, particularly middle of the night insomnia. But the picture is really worth 1,000 words. You can see the time is 3:20 a.m. She has the lights on. There's a bottle of Jack Daniels. Never a good idea for insomnia. I tell this to my patients. Nowadays, they also have electronic devices, iPhones, iPads, television. The best thing is to get out of bed, avoid staying in bed awake, and the most important thing is talking to your doctor about potential treatments that might be effective to help with the insomnia. I'm going to conclude the next 20 seconds. Sleep disorders increase the odds of dementia with Lewy body by 5 times over dementia, the dementia that we see in Alzheimer's. REM-sleep behavior disorder is the strongest prognosticators of dementia, including dementia with Lewy body. In the future, we'll see more research looking at the benefit of potentially looking at exercise in preventing the progression of dementia with Lewy body, the role of dietary factors, perhaps in RBD, the role of melatonin and other neuroprotective agents in patients with RBD to actually delay and prevent the progression of the actual dementia, and specific guidelines about agents that can help prevent the phenoconversion in patients who have RBD to prevent the phenoconversion to dementia with Lewy body. And with that, I'll conclude the formal presentation and turn the Q&A session over to the moderator. Thank you very much.
Okay, thank you, Dr. Avedon. We have a number of questions that have come in from the audience, so it's certainly a topic of high interest. The first one is, what insights are available that help people with LBD who are being medicated for restless leg syndrome and or diabetic neuropathy, but are unable to get to sleep without repetitive disruption or painful movements?
So patients who have restless leg syndrome in the setting of diabetic neuropathy, that's a very, very common condition, and there are actually some specific treatments that can actually help address both. The alpha-2 delta ligands, medications like gabapentin or gabapentin and acarbol, can actually address both the actual neuropathy and the restless leg symptoms. So the specific answer to this particular question is for the participant to really review potential therapies with his or her primary physician, because there is now one specific medication that can actually work very effectively for both, and that is the gabapentin and acarbol. Part of the problem is that the restless leg syndrome requires some degree of clinical validation. The urge to move, the urge has to occur primarily in the evening time. I mean, the urge to move in restless leg syndrome is a 24-hour problem, but it's primarily occurring in the evening time. It gets better with movement, gets worse with inactivity. But once that gets validated, and if it's in the setting of peripheral neuropathy, I think the alpha-2 delta ligands, the gabapentin and the carbyl type medications can be extremely effective.
Great, thank you. So I have two questions here that are related. So I'll do them in kind of a part A and a part B. The first part is, you know, one of the core symptoms, or one of the common sleep disorders in LBD is excessive daytime sleepiness. But how do caregivers know if somebody is sleeping because they need that sleep during the day versus if it's excessive daytime sleepiness?
That's a good question, because pathologic sleepiness versus sleepiness that everyone experiences that is not pathologic, just because sleepiness does tend to vary during the 24-hour cycle. So I would say that the first is that there are well-validated measures of daytime sleepiness to differentiate what's normal from what is not. One is the Epworth Sleepiness Scale, or ESS. And people can actually Google this. It's available on Google. The Epworth Sleepiness Scale is an 8-point questionnaire asking patients about propensity for daytime sleepiness in multiple times during the day and multiple tasks. And a certain score for the Epworth, it's a score over 10 or above, signifies a propensity for abnormal degree of sleepiness. And that would help differentiate if someone is abnormally sleepy versus sleepy because that is normal for them or everyone else, because we all have that specific tendency to feel sleepy, let's say between 1 and 2 o'clock. People in South America go and have a siesta around that period of time, or go to Starbucks, for example. But if you're waking up and you're sleepy, and if you're sleepy at 11 a.m., and if you're sleepy at 1 and 2, and at 3, and at 5, and every single hour of the day is marked by degree of sleepiness compared to everyone else. And when you're putting yourself, when you're watching TV and you fall asleep immediately at any time of the day, that is pathologic sleepiness that should be a red flag. So I think going through that specific questionnaire, and actually I'll be happy to share it with you, Angela, and maybe we can distribute it to the participants through my PowerPoint presentation. But that is a very good questionnaire to go through and for people to administer and take it and see where they are at, to know that, to get an index of whether or not that's normal or abnormal for them.
Wonderful. So I see a couple of related questions to the kind of part B of this. What is the maximum number of hours in a daytime that would not disrupt for napping times, that wouldn't disrupt nighttime sleep?
I would not say hours. That's it's a good question, but by the nature of the question, I would say that if it's hours, it's already not good. The right amount of napping is both short and strategic. By short, I mean no more than 15 or 20 minutes. By strategic, I mean between 1 to 3 p.m. If the nap is too early, it's not good. If it's too late, it can actually interfere with your ability to fall asleep at night. I often see patients and they tell me that they're sleeping 7 or 8 hours, and I tell them to be specific, and they tell me, oh yeah, I sleep for 4 hours during the night, and then I wake up and I take a 2-hour nap, and then I have another 2-hour nap between 3 and 4. or between 5 and 7. So 4 plus 2 plus 2 is equal to 8. So I want to make sure that when we're talking about sleep consolidation, we're talking about getting those 7 to 8 hours sleep in one chunk. So dichotomizing the sleep duration, it would not be restorative. Sleep is not like a bank account. You cannot take 4 hours and add 2 and another 2 hours and say it all equals to 8 hours. That would not be the type of sleep duration that we consider healthy. So napping is actually restorative, but the napping, as I mentioned, has to be short. It has to be strategic, and 15 to 20 minutes is a power nap. Any longer power nap, more than 20 minutes, will be actually undoing what we intend to promote in proper sleep.
Thank you very much. I'm sure that information is of good use to all of our listeners. So the follow-up question that I have, and I see this in the that were submitted in various forms, is, what are the treatments that you can use beyond changing the napping routine during the day? What helps these individuals stay awake so that they do have better sleep at night? We've certainly heard that there are certain medications in the psychostimulant realm that may be helpful. How do you manage that in your practice?
So management of excessive daytime sleepiness in a typical patient should not be focused on using stimulants, because the first thing is we should never substitute good sleep and use medications to give us energy. And although I see many patients who are using caffeine and caffeine tablets, and sometimes even drugs like amphetamines, because they consider their sleep very poor, what ends up happening is using those agents actually mask the serious, the management of potentially serious sleep conditions. There are a few exceptions. So if a patient has narcolepsy, which is a very rare neurologic condition that is usually diagnosed in the patient's adolescence and 20s, usually requires the use of stimulants and narcolepsy type medications like modafinil and armodafinil. But that's very rare. Oftentimes, we do have patients who are shift workers or patients who are treated for their sleep apnea but are still very sleepy. Those patients could also benefit from the use of this wake-promoting agent. But I would never, ever, ever, ever give a patient who has poor sleep because their sleep quality is reduced or because they have some other sleep pathology and they cannot maintain good sleep. I would never give that patient a wake-promoting agent because they cannot sleep well during the night. That would be a mistake because it will not go at the core of why they're sleeping poorly. And although from time to time I do hear about patients receiving those medications, it often treats the symptom without treating the actual disorder. So I would say you first have to ask the question, what is causing the sleep disruption? Is the patient not getting sufficient amount of sleep? Try to treat that. And if the patient is still very sleepy, I think we then have to go back and ask why.
Right, and I think that's exactly the situation in LBD, is that that first line of intervention really has to be looking at the environment and all of the factors maybe contributing to it. And once those are eliminated, if this is truly rooted in the disease, then you might be looking at other types of therapies.
So Angela, let me. I'm sorry. I'm just going to add one thing to that, and I'm sorry I didn't go into that mode of of treatment. One thing that can be very helpful in improving energy level in Lewy body dementia is actually light exposure, especially in the early part of the day. The other thing I wanted to mention is that there is a need to treat the daytime sleepiness even after you manage, specifically in Lewy body dementia, if you treat the sleep apnea and if you treat the RBD and the restless legs and the insomnia, and the patient is still very sleepy. We know that. We know that that's a condition that there may be centrally related hypersomnia in Lewy body dementia, much like in Parkinson's disease, that could be treated with wake-promoting agents. It's just that we don't have good data on the appropriate dose and the appropriate safety of how much and what specific treatment to use. And that's an area of much needed research that I think is currently being looked at. But you're absolutely right. That's an area that I think we would probably see more data in the coming years, because we do know that these patients are still very sleepy despite management of the primary underlying sleep disorders.
Fantastic. Thank you. So you mentioned dosing. We had a few questions about the dosage of melatonin at night. Is there a range that you typically consider for people with LBD who are using melatonin as either a sleep aid to help them get a better night's sleep or as a treatment for REM sleep behavior disorder?
Yes. So melatonin for RBD, I'll try to just make a preface by saying that melatonin is available in 3 doses for 3 different sleep conditions. For RBD, high dose melatonin. For jet lag and circadian rhythm disorders, usually low dose melatonin at 0.5 milligrams, half a milligram. For insomnia, we don't really have good handle on how melatonin should be used for insomnia. Most people use it at 3 milligrams, but the data is not very good. For RBD, however, we do have good data on dosage and good data on what works and what doesn't. And as a general rule, for RBD, we begin at 3 milligrams and increase to 6, 9, and 12 milligrams. So we increase by about 3 milligrams every 2 weeks or so. And the reason we increase is if the patient is still having episodes where they're acting out their dreams. Lately, however, we've found that patients who are using 5 milligrams sustained release melatonin actually have a slightly better benefit, and perhaps the 5 milligrams stays in the body longer, has a longer efficacy, just because REM sleep occurs later in life. 5 milligrams may theoretically protect patients later in life. If you go with the 5 milligram dose, the starting medication, the starting regimen would be 5 milligrams the dose before going to bed. Week 2, if the episodes persist, going to 10 milligrams, and then going up to 15 milligrams. If the patient still has episodes by 15 milligrams or 12 milligrams of the 3 milligram dosage, you may have to then add a second agent, usually clonazepam. And if the patient still has episodes, even with the clonazepam and melatonin, you have to ask 2 questions. Number 1, could there be some other diagnosis of another parasomnia? Number 2, is there another reason for the patient to have a refractory RBD, like having alcohol on board or caffeine or untreated sleep apnea? And oftentimes we find that in patients who are still having persistent episodes, it's usually due to some other substance that they may be taking and forgetting to tell us.
Okay, thank you. I'm scrolling through questions because I'm finding a few that have some kind of overlap again. There are questions regarding other sleep disorders and whether they are known yet to be risk factors. So there's a question of, is restless leg possibly a risk factor for LBD? What do we know about sleep disorders other than RBD, and whether they're linked to neurodegenerative diseases?
Yeah, that's a question that I generally get, and I'm glad that you bring this up, Angela. I do have patients who ask me about restless leg syndrome, and it's a risk for neurodegeneration in a patient who doesn't have neurodegeneration. And I want to preface and mention that there is no data whatsoever that restless leg syndrome puts you at risk for neurodegenerative disease, nor is there data that it's a prognosticator for any underlying neurodegenerative disease. What ends up happening is patients may think about RBD and they may type RLS instead and make a few typos, and then they get scared if they get the wrong information on Google. So I want to say RLS, no data whatsoever on phenoconversion. Untreated sleep apnea does put you at higher risk for more accelerated neurodegeneration in the setting of Alzheimer's dementia. So if someone has a history of predisposition and the right genetic makeup, or I should say the wrong genetic makeup or predisposition towards the development of Alzheimer's dementia, and they have untreated sleep apnea, the sleep apnea may derive or may put them at higher progression and faster progression simply because of the underlying hypoxemia, sleep disruption, and potentially through the mechanism that I've alluded to earlier through the glymphatic system, although that system has to be examined a little bit more carefully before we say that conclusively. But certainly, for the sake of the question that you asked earlier, the only definitively sleep disorder that has a prognostic sign for neurodegeneration is REM sleep behavior disorder.
Perfect. Now we have a related question to that. Somebody's asked, if you present with symptoms of RBD and you receive treatment for it, for example, melatonin or clonazepam, does that reduce the possibility of you developing dementia later in life?
Good question, and the answer is, unfortunately, we don't know. We probably are not going to reduce the risk of neurodegeneration if we use clonazepam, for example. But we actually, the data on melatonin is not really known. It's been thought that melatonin could have some neuroprotective effects, and it's been proposed as a candidate neuroprotective agent, but that the information so far shows that it's not really a potent neuroprotective, and patients receiving melatonin have not had slower progression than patients who are not, meaning that if you take it, it will control the dream enactment, but it would not slow the progression towards neurodegeneration, unfortunately. So much like treatment of restless leg syndrome, you're treating the symptoms, you're not treating the disease. Similar with RBD, you're treating the symptoms, you're not reversing the disease. And furthermore, in RBD, you're not lowering the risk of prognosis to an alpha-synucleinopathy later in life.
Well, it's understandable. It's unfortunate. We all wish that we have an opportunity to do something early, and hopefully research will lend some insights as to some of those disease-modifying interventions over time.
Absolutely. And Angela,
go ahead.
I'm sorry. I want to say, though, that because of the window of opportunity to use RBD as a biomarker, I don't want to have people lose hope that this is not a condition that and they're not going to be candidate neuroprotective agents. This is a very exciting sign because for the first time we are now conclusively have a biomarker that has a very strong prediction of neurodegeneration later in life. And I am certain that we will be able to come up with some neuroprotective agent in the next 5 or 10 years that will reduce, if not reverse, the progression of neurodegeneration later in life. If not, I think we will continue to look for that agent, but it would be a shame not to look for some sort of an agent to slow the progression, because we have such an effective and such a powerful and potent biomarker for neurodegeneration using RBD as a biomarker.
I agree 100%, and I think it's we're starting to see that momentum build around RBD. Those individuals who have been diagnosed with it earlier in life and who are not yet symptomatic, you know, are prime candidates. Those are very valuable potential research participants to advance LBD clinical care and our understanding of how the disease progresses over time. And ultimately, they are the people who, as you said, may be the ones that we need the most when we look at disease-modifying therapies. So we're getting close to the end of our time. I want to just wrap us up. At this stage, we have far more questions than we can get to, unfortunately, but this has been a topic that has generated so much interest, and we really appreciate your time and your expertise today. So I'd like to thank you on behalf of all of our attendees for taking time out of your schedule to join us. For those who are listening, who are interested in finding research studies and clinical trials that are currently recruiting, you'll see on your screen a link to the LBDA website that will take you right to our Participate in Research page, which lists studies that are currently enrolling. There is one on RBD right now listed there that has extended its enrollment period, so we encourage you to go take a look. We'd like to thank all of you for your time and your attention today. Our event was sponsored by an unrestricted educational grant from Axovant Sciences, but most of LBDA programs are made possible through donations. So if you'd like to make a gift, please visit lbda.org or call our offices at 404-935-6444. Our next LBD University webinar is next week, Wednesday, June 28th at 2 p.m. Eastern, and will feature one of our Scientific Advisory Council members and a member of our Board of Directors, Dr. James Galvin of Florida Atlantic University. Dr. Galvin is going to be presenting on hallucinations and delusions in LBD, so we hope you'll visit our website and register and plan to attend that event as well. So thank you again for attending our LBD University webinar, and we hope you all have a wonderful rest of the day. Take care.